the session. And if you're on Twitter, I'm not, as you can probably just tell, but if you are, please do tweet us. That is our hashtag there. So please do spread the word about this network. Next slide, please. So I'm going to just run you through the agenda. So this is the introductions and welcome section, and I am Sarah Armstrong, and I'm a GP and the clinical lead for Deterioration here at UCLPartners. Then I'm delighted to be welcoming Zena Aldridge, and Zena is the East of England Regional Clinical Advisor for Dementia and also works with NHS England and Improvement on this. And she's going to be talking to us about nursing home staff experience of deterioration in residents with advanced dementia. We're then going to be welcoming Aisha Salimi, who is a pharmacist advisor here with us at UCLPartners, and Azra Ahmed, who's a Darsi Fellow with Federated for Health in North Central London. And they will be talking to us about reducing inappropriate polypharmacy in care homes. We've then got Irene Lucy, who's the Head of Transformation and Mental Health Commissioning in Mid-Essex CCG, and she will be talking to us about improving dementia in care homes. We'll then have feedback and draw to a close, and Becky will be taking us for that session. We haven't got breakout groups today simply because the agenda is quite time-packed, but there will be ample opportunity for questions, and we really welcome that interactive element. Next slide, please. Here we are. Here are our mugshots. So I'm Sarah Armstrong. We've got Rebecca, or Becky Dubban, who's the Patient Safety Improvement Advisor. Mandeep Butt, who is Clinical Medicines Optimization Lead. Aisha Salimi, who's Pharmacist Advisor and from whom you will be hearing more from later today. And then Valentina Karas, who is our Head of Patient Safety. Next slide, please. So this map is mostly for my benefit because I struggle with geography, but this just gives you an idea of where we work. So we work across our partnership of NHS providers and universities, and we aim to improve health through research, innovation and education. So we work with our stakeholders to develop, test and implement solutions for the benefit of patients and the public. So essentially we support North East and North Central London, South and West Herts, South Beds and South West and Mid Essex. So we're quite a large geography really, and we cover 6 million people across 5 ICSs. Next slide, please. Just to give you an idea of the National Patient Safety Improvement Programme. So the National Patient Safety Improvement Programme, which is the programme in which we sit, is aimed to support and encourage a culture of safety. So we want to promote continuous learning and improvement across the health and care system to help reduce the risk of harm and make care safer for all. So essentially, we are commissioned annually by NHS England and Improvement, and we are essentially still waiting to see what that might look like for next year. But we are assured that the care home work will continue, which is fantastic because I think that this network is really making good progress. And these programmes are delivered through us. We are the Patient Safety Collaborative, and we sit within the Academic Health Science Network. Next slide, please. So a little bit of an icebreaker / getting to know each other. So I want you to put in the chat, answer this question. My perfect weekend would be spent, if you could just finish this sentence, and we'll see what comes up.
And introduce yourselves.
Oh, introduce yourself as well, sorry.
Yes, all right. We're just going to know everybody's perfect weekends without knowing who they're going to belong to.
Maybe that's better, depending on what's said. In the pub, fantastic. A lady after my own heart. Crocheting, brilliant. At the spa. With the family. Without housework, definitely. Sunshine, I like that one. Good luck with that today, Aisha. Sitting in the sunshine with a cocktail, yes. Walking the dog on a beach in the sun. Football, somewhere hot where I don't cook. Walking. Going to the woods or nature with my husband, catching up on to-do list. That's very good. With the dogs. Eating out, yes. I'm hearing no cooking as a common theme. In the garden with wine. Good luck with that today. It's tipping it down here. On a bike ride. Wonderful. Now I've got you. Oh, dogs, books and wine. I like that one as well. Fantastic. Well, now I've got you all in the holiday mood. I'm going to bring you back down to earth. Next slide, please. So it is my pleasure to welcome Zena Aldridge, who is the East of England Regional Clinical Advisor for Dementia and works alongside NHS England and Improvement. And she's going to be talking to us about nursing staff experience of deterioration in residents with advanced dementia. So welcome, Zena.
Thanks, Sarah, and thanks for having me. Just to sort of give you an overview, this was a PhD study conducted from 2018 across 3 nursing homes over various parts of the UK. It's been submitted and I've got a viva in a few weeks' time, so I'm hoping all will go well. But I'm sharing these preliminary results with you before it's ratified, but I'm sure a lot of this will resonate with many of you. So the study was undertaken at De Montfort University with Professor Kay DeVry and Professor Jane Brown as my clinical supervisors. Can we zip across to the next slide, please? I think we can probably go to the next one as well. It was kind of, for me, a big part of my clinical practice, and the fact I've worked in acute, I've worked in community, worked for social care, and there kind of seems to, as we know, lots of gaps that exist in terms of the management of people with dementia, particularly in the advanced stages when they might be coming to end of life. So the basis of this is, why do we need to know? Well, we know that there's over 400,000 people currently in care homes in the UK, and 70% of those people are likely to have some form of cognitive dementia. But of course, a lot of those people do not get a diagnosis. In fact, a large majority of them don't, particularly if they develop symptoms once they've transitioned into care. And when you kind of look at the figures, it's quite significant in terms of that's 311,000 people with dementia living in care homes. And once you go into a nursing or residential care home, very few people leave. So effectively, we're talking about places where people receive end-of-life care. And the data has transitioned over the last sort of 10, 15 years, where the majority of people used to die in hospital. The majority of people now die in care homes. So from my perspective, it was important to understand how nursing home staff made decisions when people deteriorated, because there's very little research about their experiences in these sort of situations. Next slide, please. And these are a very complex cohort of people that we're talking about. They often don't just have dementia, they have multiple comorbid conditions, are likely to be frail. And when we think about access to palliative care services, we also know that care home residents, and particularly people with dementia, even in the community, do not receive equitable access to specialist palliative care services. In fact, very few have advanced care plans, very few have anticipatory care plans. So it's unsurprisingly that we end up with a significant amount of people being admitted to hospital, often at the end of their lives, and then subsequently dying as inpatients, or coming back, in a distressed state because of the transition that they've experienced within the hospital setting. The difficulty also is, once that we get to a certain point with dementia, when we talk about the advanced stages, these are patients that are no longer often able to communicate or have mental capacity to engage in the decision-making process. So if conversations have not been had with family, friends, professionals, we almost have to consider the multiple opportunities or decisions that we can make, and think about what might be in the best interests of that person. And that's incredibly difficult if we as clinicians don't know that person particularly well. These situations often happen out of hours. It may be a paramedic that has to attend, who has, their own priorities and policies that they have to deal with. So it's important to understand how we can consider the role of the nursing home staff and how they might be improving these outcomes for patients. Next slide, please. One of the issues with dementia particularly is that it's quite difficult to prognosticate for people who are not particularly confident and competent in managing people with advanced dementia. If we look at the prognostic clinical indicators, they're fairly subjective, and again rely on you knowing the patient particularly well. And they often sit on several trajectories, because, as I said, if they have multiple comorbidities, they might be on a decline in terms of demential frailty, but they might then have other long-term conditions that have a more stepped decline. So they might actually be declining over 3 trajectories, particularly if they have malignancy as well. there's a not a universally agreed context of what deterioration is in this cohort, because of the way that it's can be quite insidious in a decline. Often there are what the participants in this study called tipping points, where you can start to see things change, but from a clinical perspective they might not be seen as an acute deterioration in their health. So there was a very different challenge there. But equally, often from a health perspective, we look very much at a health decline from a physical health situation when we're looking at deterioration. But what the nursing home staff were saying was equally they were concerned about the emotional, psychological and wider deteriorations that patients might face when they go into hospital, and balancing those up was actually quite difficult. We still have this kind of medical model versus relationship model of care. And in nursing homes, what we're advocating is a relationship model of care, and then we're expecting the patients to fit into a medical model of care the minute that we engage with them as health providers. So it's a bit like mixing oil and water. So you might be coming from very different perspectives. Ultimately, we all want the best for the patient, but what we consider the best to be and the right thing to do might be very, very different. And so there's this kind of conjecture as well about the perceived value of nursing home staff within the engagement of the decision making. And a lot of that depends very much on the leadership, the experience and training of those who are often clinical leaderships within the home, but also in the MDTs that are actually engaging with the care home staff themselves. Next slide, please. What came out of this study was that actually a lot of the staff were using not only their clinical knowledge and their understanding of the patient, but they had a moral compass that they were referring to actually inform their decision making. And if we go to the next slide, you know, what they felt they were having to do was try and balance what was morally and ethically right, with what was procedurally and clinically right. And those things often don't dovetail. An example of that was that one care home or nursing home had a lady who had quite a significant tumour, an esophageal tumour that they knew was going to rupture. She had advanced dementia. She was being palliated. They had stat doses of medication for when this happens. They'd even got black towels, so if this lady bled a lot, it wouldn't be so overtly distressing for the family. But the issue for them was the CD cupboard was the other end of the building, and 9 times out of 10 there's only one clinical member of staff on duty. So they removed the CDs from the cupboard and left them in the patient's room. Now, from the perspective of the CQC, that was actually completely inappropriate thing to do, but what was morally right for that patient was the fact that the medication was within easy use, that they could use instantaneously within the situation that that particular tumour ruptured and this lady was going to come to her end of life quite rapidly. So we've got this kind of dichotomy where everybody's trying to do the right thing. We might not be able to fit that. Next slide, please. But what was fundamentally underpinning a lot of the views of the staff was not only did they want to do the right thing, but because of the fact they felt that most of their patients were going to die in their care, one of their priorities was ensuring that people were able to have a good death, or as best death as they possibly could within that environment. And for those people that, you know, these were people that they'd become attached to often, they'd been caring for them a long time, they'd got to know them, they'd got to know their families. And when we talk about the soft signs, they were very, very clear on what the soft signs of deterioration were, because they knew the changes with these individuals. They don't necessarily need to know how to articulate those concerns, but they recognise that something was changing. And they found that actually the biggest thing that caused them distress whilst doing their role was when someone died in pain or distressed, or was taken from the care home and taken into hospital and died in the hospital, particularly when they knew that wasn't what the person's wishes or the family's wishes potentially weren't. Sorry, excuse me. So next slide, please. So I'm whipping through this. It sounds very simplistic, but I'm probably sure it wasn't. But the factors influencing the decision making, we're trying to find out the wishes and preferences of the families, of the person themselves, if they were able, as early as possible. And I think when we look at respect documentation and things like that, a lot of the focus is on resuscitation orders, things like that. And actually, this was the much softer side of what advanced care planning should look like. It was finding out, about their spiritual needs, about who they might want with them, where their preference would be at their preferred place of death, those sorts of things. What the staff also did, which seems to be something that they felt as a wider system we don't do particularly well, was they prepared for the inevitable, and the inevitability was death. That, whether it be 6 months down the line, whether it be 12 months down the line, patients were going to die. Almost like it almost felt that they were a hospice, but without the infrastructure around it, because ultimately people were not improving. They were not, they're not going to walk out well. They were coming to their end of lives, whether that be imminently or later on. They also then used their prior knowledge and experience to pick up these softer signs that they, again, might not have been able to articulate, but they could see these tipping points where they could see that someone was changing to a degree and felt that that was indicative that they might be moving on to a latter stage. But again, it was about enabling them to do that was knowing and seeing the person beyond the diagnosis. And they felt that a lot of clinicians just saw a person with dementia, and any deterioration that was linked to that person was attributed to dementia, a lot of diagnostic overshadowing, as opposed to seeing that person in a more broad sense and looking for any acute changes, anything that was remedial and could be treated. So they felt that although they wanted to support someone to die well, they were also keen to make sure that people didn't die unnecessarily early and that they were made comfortable during that time. Next slide, please. But in effect, because they were emotionally involved in these situations, they were experiencing a lot of moral distress when they thought that they couldn't do the right thing. And that might be, even with the best intentions of all around, they tried to put everything in place in the nursing home. But say, for example, it was a Friday night and ambulance crews were called and they felt they had no option but to convey someone to hospital. They were really distressed by that. And I think what's really interesting is this was done before COVID. This data was collected before COVID. So if we kind of think about the impact COVID has had on care home staff who've been facing these situations more and more, and actually probably more powerless than they were at this particular point, I think we start to get to see a picture of the wider impact on care homes and actually the moral impact that it has had upon them. Next slide, please. So in terms of trying to mitigate the risk of experiencing moral distress, they would aim to do their best, in terms of challenging, negotiating, advocating for the patients. But then there would come a point where they actually had to demonstrate moral courage. And that might be by trying to go to another health professional to try and get a second opinion. It might be about breaking the rules. And often, that example I gave about the controlled drugs was one of many where they had to bend the rules in a way that they felt was morally appropriate to ensure they got the right outcome for the patient. And as long as they had felt that they had used their moral compass to guide them and demonstrate moral courage, and the outcome was the best it could be, they could reduce the risk of moral distress to two other moral positions, which were moral well-being and moral resignations. Next slide, please. So moral well-being was that situation where perhaps they felt that they had enabled someone to die well, they hadn't been in pain, they felt that they'd done their best and they couldn't do any more, and the outcome was that that person had died peacefully. And moral resignation was something where they didn't think that the outcome was necessarily the right one, but they'd done their best and the patient hadn't suffered in any way. So, for example, that might be that a patient had to be transferred to hospital because there wasn't anyone to administer a syringe driver, for example, out in the community. So although ideally they would have liked that person to stay in the nursing home, if there was no option and that person was going to be in pain for any great length of time, they would prefer them to be admitted to hospital, even if it wasn't the best, what they felt was the right thing to do. But they recognised that there was a lot of constraints on other peers around this. And And you know, the dying in pain was something that was often the thing that caused them the most distress. That they said that they often had difficulty in getting end of life medication prescribed. They often found that the dosage wasn't prescribed in such a way that they had a sliding scale, so they were having to rely on others to come and give stat doses. And some of those homes actually had both nursing beds and residential beds. And of course, it was more challenging for them in the residential beds because they didn't have the clinical responsibility for those patients. They would actually have to ask for district nurses to come out. And that was another occasion where often they felt that breaking the rules was appropriate. They felt that as clinicians working, you know, registered clinicians who could actually administer that medication to someone in a nursing home bed, yet they'd got someone in the residential care bed who was suffering, they would not feel that it was clinically appropriate for them not to administer the medication, although in terms of policy and procedure, they should have waited for a district nurse. So the reason I think this is really important in terms of deterioration is we need to have a better, obviously we try constantly to implement protocols and pathways to reduce inappropriate admissions, to manage deterioration more effectively. But I think what we sometimes miss is the narrative from the nursing and residential care homes on how they determine when someone is deteriorating and what they can actually do to support us in managing that deterioration, particularly in the short stay or the short term. You know, if you work in a hospital and someone deteriorates, you've got a whole system wrapped around you that can come and support you within seconds. If you're in a nursing home in an isolated area in the middle of the night, you are one clinician having to make some very complex decisions about individuals who may or may not be dying but have clearly deteriorated in some way. So to conclude, if we can have the last slide, please, it's you know, we forget that they are often faced with very complex decision making. They're often having to negotiate across multiple people within that decision making process, including the family, the person themselves, health professions. And we don't necessarily have a grasp on the importance of their role in looking after the patients and that relationship and emotional based knowledge that they have of the individuals. I think there's a need to describe a common language of deterioration and that risk versus benefits about an acute physical deterioration against the risks played against that emotional, psychological distress that often people with dementia can experience if they go into the acute setting. You know, and actually we perhaps need to be more clear and more prepared to have those conversations earlier on. And again, thinking about what's right for the patient may be contravened by the policies and processes that are in place. And often the policies and processes in place within care homes do not align with those in the wider health and social care system and vice versa, which means we end up with a bit in the middle where nobody's quite sure what the right thing to do is. So I think going forward, we need to understand that clinical decision making in some areas and in a lot of areas does involve emotion. It does involve, you know, that need to look at not just an algorithm or a decision tree, but actually include that relationship skilled knowledge that these nurses have. On one hand, we advocate that within care homes, saying we want them to build relationships, yet then we verify them when we say they don't kind of work to the medical model. So it's kind of striking that balance in the middle. I had to say it was a very humbling experience. I was very fortunate in the 3 nursing homes that undertook this research that actually all of them were very well clinically led by a nurse who was both a manager and a nurse who was a deputy manager. And they'd all undertaken gold standards framework training and accreditation. So you could argue that there's limitations in the fact that this was a cohort of participants who were fairly adept in end-of-life care. But I think if we know what good looks like, we can then start to understand why sometimes things don't look as good. So I don't think that's particularly a failing. So it's a fairly whistle-stop tour through, but I thought it was probably better to kind of skim over the surface and enable people to ask questions as opposed to kind of talk too much about the theoretical concepts that came from it.
Thank you, Zena. Right, so has anyone got any questions for Zena? You can either put them in the chat or pop your hand up if you wowed them all.
Deathly silence. That was really difficult for me to actually squeeze that into such a short time, because we've had the conversations before, you know, Becky, and I can talk for hours about this in quite detail, but so it's quite difficult to condense it into.
So I have a question, and bearing in mind that we have an extremely varied attendance to this, from GPs to care home managers to everyone, pharmacists. What would your I guess recommendations be from this for this group? What can they take forward from this? What can they think about in their work, or how can we make changes based on what you found?
Can you hear anything, Bonnie? Can you hear the chat?
I think one of the things we need to learn is how we develop the MDTs around the care homes, and make sure that we have the right skill mix within those MDTs to meet the needs of this complex group of patients. You know, just formulating MDTs from the staff that we've got and putting bums on seats is not enough. It's about having that level of skill that understands the complexity of these patients. After all, these would have been patients that would have been under the care of a geriatrician not many years ago. And we're asking GPs to take on this extra role and responsibility at a time when things are incredibly stretched already. So I think getting that skill mix right is very important. I think we have to look at patients with dementia differently. I think we need to start doing advanced care planning much earlier in the trajectory. We shouldn't be waiting till someone's gone into a care home before we start having those conversations. But for those patients where that does happen, then we need to be starting to have those immediately. You know, not just which funeral director would you prefer, but, you know, what would you like to happen if, you know, this is what end of life in dementia looks like, and, you know, be more bold in that. And I think we need to look at this from more of a palliative care approach, as opposed to managing acute decline, and actually thinking about it in a different way. And for me, that feels like the gap at the moment is a lack of a palliative approach, where, you know, as I said, these are patients that, you know, are not likely to have a long life once they go into a nursing home. There are very few people with advanced dementia who live any great length of time whilst in the care home setting. So, you know, things like, you know, we talk about when a patient loses weight at their end of their life, we're asking staff to do must scores and then refer them to dietetics. You know, there comes a point where we have to be honest and say this person's dying, you know, and this is part of the dying process, and we need to plan accordingly. But I think, again, we kind of get on this rabbit sort of world of following a process, as opposed to actually thinking what's going on underneath for this patient.
And putting the patient in the middle of it.
Absolutely. You know, and I'm prepared to be shot down on that, by all means.
Winnie, are you going to come in and shut Zena down?
Not at all. Hello, everyone. Thank you. I just wanted to add something else to what Zena is saying, is that I think it starts, for me anyway, it starts with appreciating the opinion and the value of the care home staff, because normally the deterioration conversation starts with them saying, I'm a little bit worried about. But until a professional person comes in and states that it is weight loss, the rest of the MDT sometimes doesn't quite accept that it's weight loss, because the person who was saying it is somebody who's working in a care home. So I think sometimes in some situations that we've been across is not listening and valuing the care home worker who knows these people sometimes better than a lot of even family members know the resident.
Absolutely, and that came across very strongly in this research. Actually, was knowing the patient, knowing the person. Actually, because we steered away from saying knowing the patient, it was knowing the person or the resident, because they're not patients to the, you know, they're in their home, aren't they? They are looking after them in their home. Though they knew when something wasn't right. They knew when there'd been a change. And like you say, they often knew them better than their family did, because at that point in their life, so because they were with them so much of the time, they were picking up on things that, you know, family members might not have done because they weren't doing personal care, for example. They weren't with them for the length of time. And certainly there was a devaluing of their opinions, and as opposed to being seen as partners in decision making, they were often, you know, the recipients of the decision, and they had to act upon it. And there was certainly an imbalance. And I think, you know, when we're talking about avoidable admissions, I think we're missing a trick if we don't listen to our care home staff and get their opinions earlier when they raise a concern. But equally, when they say that, you know, when we talk about someone's end of life, it's about ensuring that that person has a good end of life, as opposed to better management of an acute deterioration.
Thank you, Winnie. Good point. And Michael in the chat said, well said as well to both of you. So well done. Anybody else got anything they'd like to? We've got a minute or two before we can move on. So has anyone else got anything they'd like to, any thoughts on what Zina's presented, or questions or reflections? No?
I guess one of the things I probably want to add, Becky, is, you know, tools are great. SBAR is great, news, all of those things, but they need to be, they shouldn't be used in isolation. They should be used in conjunction with the skills and knowledge of the care home staff. And I think one of my concerns is that we're reliant so much on tools that we're actually missing what actually is a huge bit of intelligence that the care home staff often have. So I think, you know, it has to be done in conjunction with working with the care homes, not as an aside. Doing with rather than doing to, I guess.
Yeah, it actually makes me think of, as another piece of work, we have there's a paediatric early warning school for acute trusts, which is the other end of the spectrum, but on that is parental concern. And every paediatric nurse I've ever spoken to is like, if a parent is concerned, we will listen. And actually it is that kind of principle of, we know this person really, really well. We know they're not right, there's something wrong. And actually it's getting the rest of the system to listen to the people who know them the best.
Absolutely.
Lovely. Oh, Michael, you've put a question. Are homes having good GP support with end of life? I guess that's out to...
it's a bit of a postcode lottery, I think, is probably what I think. We have GPs who have a lot of experience and feel quite confident and competent in palliative care. Others who don't. You know, it's not something that everybody's comfortable with. So I think, you know, that there's room to look at this wider, and that's why I think the MDTs are important in getting the skill mix, because, you know, not every GP is going to be a palliative care specialist, but if you get the right set of people around you, then ultimately you have the skill set to be able to work collaboratively to make decisions, as opposed to unilaterally. But part of that MDT has got to be the care home and their views. But I think, you know, I'm actually about to take up a new role as a care home at scale clinical lead, because I think, you know, there's a lot to be done in this space. And I think, you know, it's about trying things. It's not working as it is. We need to think differently and more proactively about it.
Thanks, Zina. And I think some of and Sarah probably agree, the conversations we have from across our patch, there's a real variety in the level of GP involvement within care homes. And it's something that, especially around not just dementia care and end of life care, but recognition of deterioration, and that universal language around it. So yeah, I think this network is a really good forum to be able to start having those conversations. Sarah, have you got any thoughts on that before we move on to?
Sorry, it just took a minute to get off mute. No, I just reiterate what you said. I mean, by and large, often GPs are fantastically engaged and really providing that positive service, but sometimes for whatever reason it doesn't always happen, or there's difficulties with alignment between the care home and the GP, so it's difficult to know who's actually responsible, so that can sometimes be an issue as well. But yes, unfortunately, you know, it is quite a variable a variable thing from what we've experienced.
And thank you to everyone who's sharing in the chat who about their experiences and the difference in the services. I think it's really important. That's one of the things I love about this network is we have care home managers, GPs, support services, everybody on this call, so everybody can hear each other's perspectives, and I think that's really important. Just conscious of time, thank you very much. I'm sure Zena won't mind if you've got any more questions for her, either put them in the chat. Are you staying around for the rest of the session, Zena? Are you able to? Yeah, lovely. Either put them in the chat or get in touch with me, or I think, Zena, you put your information on the slides. Yeah, so without further ado, I'm going to hand over to Aisha, who is going to talk about a project that she's done around reducing inappropriate polypharmacy in care homes. And then that's going to segue very nicely into Azra, who has taken that project on in North Central London. So Aisha, over to you.
Lovely, thanks, Becky. So hi everyone. So I'm Aisha. I'm a pharmacist advisor at UCLPartners. I did my Darsi Fellowship in 2018-19 at the Health Innovation Network, and I know I've got some of my colleagues from here today, so welcome and thanks for joining. So it says Darsi Fellow there on the slide because that's when I did my course. And I'm just going to talk you through what I did for my project, so how I started it, how I got to the things that I decided to do, and then my learning at the end. So next slide, please. Thank you. So firstly, why did I think about doing polypharmacy? So polypharmacy literally means many medicines. And in 2017, the World Health Organization announced polypharmacy as a third global patient safety challenge. And there was an aim to reduce severe avoidable medication-related harm by 50% over 5 years. There's been a study to show that obviously with the more medications that you have, there is going to be more risk of adverse drug reactions. And this study showed that if you have 2 medicines, that there's a 13% increased risk. And if you have 7 medicines, there's an 82% increased risk of adverse drug reactions, which is a huge number. And on average, care home residents are 85 years of age and take just over 7 medicines a day. And that's the average. So next slide, please. So just talking about the average care home resident, so you've got an 85-year-old woman, a life expectancy of 12 to 13 months, and they would also have complex care needs. They'd have 6 or more diagnosed conditions, 7 or more prescribed medicines. So as we mentioned, 82% risk of adverse drug reactions with that. They'll also have a combination of physical frailty, disability, and mental health conditions. And obviously the older people are the fastest growing section of the community, and the number of people over 85 are expected to double within the next 2 decades. Next slide, please. So first, I wanted to find out about polypharmacy and just have a bit of a brainstorm of what has given us this problem of polypharmacy. And I felt it was twofold. So if we can just click through this slide, thank you. So firstly, it would either be overprescribing. So we're prescribing way too many medicines. And in combination with that, there's a lack of deprescribing. So we're not stopping enough medicines. And that's how we've got this problem of polypharmacy. If we break that down a bit more, so overprescribing, what are the reasons we could have that? So maybe it's because non-pharmacological options are not being considered. So we're going straight to drugs a bit too quickly. It could be that clinicians are seeing a new diagnosis, like a side effect of a drug, rather than a new symptom. So somebody comes to a GP and says, I've got this new symptom, and it might be that that symptom is due to a side effect of a drug. And rather than looking at stopping that drug that's causing the problem, they will just see it as a new symptom and prescribe a new drug. So that could be an issue as well. There might be misdiagnosis, so just diagnosing the wrong condition, overdiagnosis, so actually diagnosing something that isn't actually there. And I think there's one more there. Yeah, drug companies obviously could be encouraging prescribing. So 20 years ago, we would probably have just prescribed medication for those people that are unwell. We now prescribe medications for people who are well, because we are doing preventative medication. So that's a lot more prescribing that maybe wasn't there 20, 30 years ago. So there's a lot more medicines being prescribed. And then on the other side, if we look at lack of deprescribing, why are people not stopping medicines? It could be lack of information. So if you go to your GP practice and one of your medicines have been started by secondary care, so a consultant in hospital, if that GP doesn't know the reason that that medication's been initiated because the hospital haven't given enough information, that GP is going to be reluctant to stop that medicine. There are deprescribing tools out there, but maybe they're not being utilized. Fear of litigation. So it could be if I stop your statin or if I stop one of your medicines and you have a heart attack or you have a stroke, are you then going to sue me as a doctor because I've stopped something? And then obviously lack of time. So in 10-minute consultations with your GP, can they really do an extensive medication history and medication review? Not really. So we're struggling with all these things. And this is why we now have this issue of polypharmacy, which is so huge. Next slide, please. So in my project, I know I wanted to target care homes. So I went out and I presented at care home forums. I just presented what my title was and what I wanted to achieve. I obviously didn't know how I was going to do that. I just wanted to try to reduce polypharmacy. So I emailed all the care home leads. I presented to the residents and relatives as well. I then had focus groups from that. And I had individual meetings with GPs and pharmacists. And from all those meetings, it came out that anticholinergic medicines is an issue. And I'll explain a bit more about that, I think, in the next slide. Go to the next slide, please. Right, so anticholinergic medicines. So what are they? They are a group of medicines that block a chemical called acetylcholine from binding to specific receptors, so muscarinic and nicotinic receptors. What you need to know is that they have side effects like dry mouth, reduced sweating, and dry eyes. And also they directly block the beneficial effects of dementia medicines. So if you have a resident in a care home who's taking medication for their dementia, and then you give them an anticholinergic, you are blocking the beneficial effect of their dementia medicines, which obviously you don't want, and you are therefore worsening their condition by giving them that. There's also an increased risk of mortality in people with dementia with long-term use of anticholinergic meds. Next slide, please. So then we have anticholinergic burden. And I'll just explain that a bit more. So there's some medicines that have more anticholinergic effect than others. And there's several calculators out there on websites that you can put in the medication names and you can come out with what is the total anticholinergic burden of all the medicines that this person is taking. And I've got a couple of examples there. So all medications, they would be assigned a score, either 0 to 3, obviously 3 being a high anticholinergic effect and 0 being nil. And medication with the highest score are obviously the greatest risk of giving you these adverse drug reactions that we've just mentioned. When you add up all the scores, you calculate the anticholinergic burden. There are actually several lists, and some of them have got slightly different numbering. And currently, there isn't a consensus on the anticholinergic list that we should be going by and specific score that we should be going by. So there are several different lists of anticholinergic burdens. Next slide, please. Thank you. So after that, my next steps were to go and see the care homes that wanted to work with me. So I did some training in 3 care homes for the nurses and the carers around anticholinergics. I then provided them with a list of medicines that are known to be high anticholinergic activity, and I wanted them to highlight to the pharmacist or doctor if they were giving any of these medicines to residents with dementia, so that those medicines could then be reviewed. I then gave them a poster of common side effects of anticholinergics, as well as medication classes that contain these types of drugs. So like, for example, anti-allergy meds like chlorphenamine, you might know it as Piriton, is one of the medicines which is an anticholinergic. I then gave them a table to collect data so they could write down which resident, what anticholinergic medicine they're on, and they could hand that to the GP or pharmacist to say, can you please review these medicines? So the aim of all of this was to highlight medicines to be reviewed with an aim to either stop or reduce the dosage if it's not providing the benefit to the resident. Next slide, please. Right, so in these 3 care homes then, so the first one we had 14 medicines that were highlighted, so 12 were reviewed, 6 of those were stopped and 6 had no change. And unfortunately 2 of them, they didn't get around to reviewing that while I was doing the project. The second one, we had 5 medicines highlighted to be reviewed. A couple of those were stopped. One was actually switched to a non-anticholinergic alternative. So that is another option. You can either switch it to a medicine which has less anticholinergic activity or one that has no anticholinergic activity. So that's something else you can do. And a couple were unchanged there. And then the last one, we had 4 medicines highlighted, 3 were actually stopped and 1 was switched. So in total then, 21 meds were reviewed, 11 of them stopped, 2 of them were switched, and 8 were unchanged. And the reason they were unchanged was for clinical reasons. So the GP told me that they didn't want us to switch it because they felt clinically that resident needed those medicines. Next slide, please. So the last care home felt that actually they were working on anticholinergics already and they didn't want to address that again. So we decided to do something slightly different and go down the non-pharmacological options route. So we had a bit of a discussion to think about what non-pharmacological options we could go for, had a bit of a meeting with the carers and nurses, and they decided that actually they would prefer to increase fibre intake for those residents with constipation rather than giving laxatives. Obviously, we had an exclusion criteria. So any residents that were on opioids, so like codeine, morphine, that we know causes constipation, we didn't want them to be without laxatives. So we excluded them from this study. Anyone with a GI condition, so, you know, if they needed laxatives for clinical reasons, we didn't obviously want to take those away from them, and then anybody on long-term use of laxatives. So those residents were not included in the study. Next slide, please. So the results then for this last care home, we had 6 residents included. We increased the fibre intake over 4 weeks and we recorded the effects, and we ended up reducing the use of laxatives by approximately 60%. So it was doable. It was great that we reduced it by so much, and I think that the care home really appreciated that and actually really liked that they could do that and avoid use of medications. Next slide, please. Right, so just some other outcomes then from this project. So we involved 4 care homes. It was a mixture of nursing homes and residential homes in both South East and South West London. We involved relatives, residents, GPs, care home staff and pharmacists. We engaged with care home leads in the CCG and local authority. And it was a bit of an international project, to be honest, because even though like I liaised with NHSE, CQC and NICE, but I also had some conversations with people in Canada and New York, just because in Canada they have a de-prescribing network. So I was liaising with them there. And in New York, they actually have the offices for MD Calc, which is an app a lot of clinicians use to calculate things like CHA2DS2-VASc, you know, so stroke risk, has bled, so bleeding risk, or, you know, kidney function. So they already have some calculators on there, and I thought maybe they could add anticholinergic burden as a calculator on there as well. Unfortunately, it didn't come to fruition before my project, but it might be something in the future someone can take on. Also, I raised awareness of anticholinergics and the risks of polypharmacy. I created a leaflet and poster to encourage medication reviews and shared decision making, and also a poster for staff outlining the main side effects of anticholinergics. Next slide, please. This was the poster that I developed, and it's basically meant for care home staff, but it can really be used in any area. You could put it even in like GP practices in primary care, in secondary care. It's just to let people know what anticholinergics are and the side effects of them. So if you notice any of these symptoms in your residents, you might go, oh, actually, this person's been feeling dizzy since they started that new medicine. Is that maybe an anticholinergic? Should I get that reviewed by the GP? So it's just to kind of raise awareness and let care home staff know about what anticholinergics are and their side effects. Next slide. And this is a poster about medication review. So really wanted to have a shared decision-making theme to it. I wanted it to be open. Obviously, the patient can say, no, I don't want to review my medicines right now. So then you go down the right-hand side and say, okay, maybe now's not a good time. We can address this later. When would be a better time? You know, you come to me, you let me know. Or if they say yes, then they can have that conversation about their medicines and just open up that dialogue. Next slide, please. So this is a leaflet that I put together as well. So again, this is something that can just be in, you know, receptions and GP practices or secondary care, anywhere. If you can just go over the next couple of slides. So that just gives you a bit more information about what's in the leaflet, and then obviously just some details at the back that the patient can write in themselves. So my project was actually accepted at some conferences, which is great. So I had a poster accepted for the National Dementia Congress in 2019. I presented Darsi Fellowship Year at the Clinical Pharmacy Congress in 2020. And I wrote an article on this project, which was then published in the Journal of Dementia Care in September, October 2020 as well. Next slide. So lessons learned from this Darsi Fellowship Project, then don't underestimate the time it takes to build relationships and arrange meetings. This is the first time that I had to do anything like this, and I was shocked at how long it takes, but obviously everybody's really busy and you have to try to align people's diaries. So it actually took a lot longer than I had originally thought it would to make meetings. Go where the energy is. So where people are interested in starting a project, go to them. Sometimes obviously if people are busy and they're not really open to it, it'll be difficult to start a project. So, and make sure you're arranging your meetings around your stakeholders' diary. Really important to take the time to understand the system that you're trying to affect change in. So I hadn't really worked in care homes before. It was quite a different sector for me. I'd only been in hospitals. So I had to really try to understand how it's different to other sectors before I could actually try to make any change there. Also listen deeply, so listen with an open heart, open mind. This is a very Darsi kind of phrase, but it's really important that you're listening to people. And as was mentioned previously, care home staff aren't always listened to, and they're not listened to by a lot of people in our, in the healthcare sector. So I really think it's important to listen to people. And then lastly, challenge yours and others' assumptions. If there's something that you think might make a difference, but nobody's tried it before, doesn't mean they've not tried it because it's not going to work. It might be that they just not tried it, and you might be the first person to do it, and you might be surprised that actually something different will work. So challenge yours and others' assumptions. Next slide, please. So I've got a few references there that I've used for my presentation, and the last link there is the Health Innovation Network website, which has got all the information of this project. All the resources are on there, so if you want to access any of that, then just follow that link. Next slide. And that's the contact details for the Health Innovation Network. But if you want to get hold of me, that's my email address there, so please feel free. And we've got a question, and then maybe we can go to Azra in a bit. So Sarah, you can come in.
Yeah, thank you. That was really interesting and really informative. So thank you so much. My question was simply, you put in the presentation about the websites we can go to look at anticholinergic burden. Perhaps you could just give us 3 drugs or 3 classes of drug that are either very high in their anticholinergic burden or very commonly prescribed, so that when we're all dealing with our residents or our patients and we see a drugs chart, a light bulb can go off and we can think, okay, this person needs a med review.
Yeah, I mean, I probably couldn't tell you all of them off the top of my head. I haven't been clinical for a while, but chlorphenamine definitely is one that we did come across quite a lot. So that's something. And there's some that you might think doesn't have any anticholinergic activity, and actually there is some, like it might have a score of 1. So I think it's important to just look them up, even if you think, oh, maybe it will, maybe it won't. If you've got somebody who's got any of those symptoms on that poster, I think it's really important to just try to look up their medications and see whether they have any score at all on there.
Great, thank you.
Thanks, Aisha. There's a question in the chat that you might want to answer from David, but maybe if you do that in chat, I'm just conscious of time. So if I hand straight over to Azra, and then if there's anything sort of discussion based at the end, that'd be great. All right, Azra, over to you.
Thank you. Hi everyone, I'm Asra. I'm a senior clinical pharmacist and I work for Haringey GP Federation. I'm also a current Darsi Fellow working with North Central London Integrated Pharmacy Medicines Optimisation team. Next slide, please. So today I would like to talk about my Darsi project, but before I do, I just want to give you a bit of background on the scoping phase which helped develop the project plan. So my challenge was to look at ways to address problematic polypharmacy. So problematic polypharmacy refers to patients that are on multiple medications and either the medication is no longer indicated or the patient's experiencing side effects or harm associated with that medication. There's also another current Darsi fellow working with me in the North Central London patch, and what we aim to do is to come in with a fresh pair of eyes and really try to understand the context and the size of the problem by speaking to as many people within the system to help formulate our project plan, which of course is evidence-based and patient-centred. Can we go to the next slide, please? So in terms of the scoping phase, what we try to do is initially try to map our stakeholders to the geographical locations to where they were based, including sort of primary care, secondary care, community, care homes, as also mental health, to ensure we were gathering all perspectives from different parts of the system. In terms of stakeholder meetings, we conducted one-to-one interviews with multi-professionals. We also had some focus groups with patients as well as carers, and also spoke to sort of focus group with clinical pharmacists as well, working in primary care. And our line of inquiry was to really understand the barriers to addressing problematic polypharmacy and what more could be done to address these issues. So the bulk of the inquiry happened last year from between October to December, and we got a chance to speak to over 70 people across the system, and we then use this feedback to map it to a framework model, which is on the next slide. So we mapped it to the socio-ecological framework, which breaks it down, the themes into sort of individual level, interpersonal, organisation and cultural. The themes that emerged were overlapping and interacting, of course. So at the individual level, some of the feedback that we got was, the person's health literacy, the attitudes and values with regards to medication taking behaviour, and also the real or perceived lack of agency. At the interpersonal level, some of the barriers were looking at the individual as a clinician and their own barriers to addressing problematic polypharmacy, but also at the interaction between a patient and a clinician, and also between clinician and clinicians interaction, and also some of the wider issues that exist within sort of organisation and cultures that were potential barriers. Next slide, please. So this really helped to identify some of the priority groups, and this is some of the feedback that we got from the stakeholder meetings in terms of which areas we should that there is potential to focus on. I decided to focus on care homes, and looking at the frail and elderly population, and what was apparent was that from the feedback that we got,
just saw something flash up about you. Hey, where are you going? Don't know yet. Okay.
Can everyone just make sure that they're on mute, please, if you're not presenting?
So so the patients were identified, so the care homes patients were identified as a priority group from the stakeholder meetings. The pandemic did highlight the inequalities and gaps in care for our care homes residents. Given that I am a primary care pharmacist, what I did want to do was focus on sort of PCN project. So looking at our primary care pharmacists and really supporting them when it comes to structured medication reviews. And another feedback that came back from the stakeholder meeting was that there was a huge variation with regards to confidence and competence when it comes to deprescribing for our PCN pharmacists. So going forward, a targeted approach was required for this project focus. Could I go to the next slide, please? So in terms of my project, what was agreed was I'll be looking at ways to reduce problematic polypharmacy, with a particular focusing on medications that had a high anticholinergic burden. And the aim was essentially to reduce the anticholinergic burden score and in turn, improve patients' quality of life, reduce falls risk and reduce hospitalisation. And the aim was to deliver this by our PCN clinical pharmacists by delivering patient-centred structured medication reviews, which is part of the PCN DES contract. Next slide, please. So in terms of evidence, there is an increasing number of systematic reviews and meta-analysis that reports that drugs with anticholinergic effects are associated with increased risk of cognitive impairment, dementia and all-cause mortality in older people. One particular study back in 2011 included patients with over 13,000 UK men and women over the age of 65. And what was reported was that 20% of actual participants who scored an ACB of 4 or more had died by the end of 2-year study, and that was in comparison to 7% who had an ACB score of 0. And they also reported that for every additional anticholinergic burden score, the risk of dying increased by 26%. And the increased risk from anticholinergic drugs were shown to be cumulative. So the more number of drugs that you were on and the highest strength had the most consequent as a result of that. So there is that growing evidence in terms of focusing on anticholinergic medications as an area to potentially deprescribe if it's prescribed inappropriately. Next slide. So in terms of my deliverables, I'll be focused on sort of 5 elements. So one element is looking at education and training to help deliver better structured medication reviews for our care homes patients. There's an element of raising awareness and also sort of encouraging MDT working and collaboration. Next slide, please. So the first element, looking at education and training. So what I would really like to do is really upskill our PCM pharmacists to review the appropriateness of anticholinergic medications and really improve their confidence to de-prescribe where appropriate. I hope to deliver this by running a series of education and training sessions for our pharmacists to raise awareness of the issue and also helping them support them when it comes to de-prescribing and as part of the structured medication reviews, and also making sure that the decision is shared decision with the patient and the carer. As part of that, the next element is actually delivery of structured medication review. So one of the privilege of working with the Harrogate is that we do have a centralised team. So we have almost 30 pharmacists, so we can take a bit more of a structured approach when it comes to upskilling the workforce. So the first bit was running a baseline search to identify patients, to stratify the patients. So we identified patients that had an ACB score of 3 or more as our target population. The second element was data collection for clinical intervention, so we can really capture that quantitative data so we can actually report some of the interventions going forward, and also supporting our pharmacists, given that we do have a pair network within Harrogate. Next slide, please. The third part was raising awareness. So amongst our health and social care staff, so the care home staff as well as other multi-professionals, about anticholinergic side effects medication, so they can also flag up the need for a structured medication review, or if the patient is presenting with some of the side effects associated and making that link with the anticholinergic burden. So some of it that Aisha was referring to, hopefully embedding that as part of this project. And last but not least, looking at MDT working and collaboration. So really embedding our PCM pharmacists within the wider network so that they are reviewing complex patients and sort of MDT working, and also sharing the learning and improving collaboration to ensure that there is sustainability of outcomes, and hopefully set up a community of practice for care homes in North Central London discussing these issues. And hopefully there is the interest in this forum of being involved and being part of that too. Next slide, please. So this is just a slide about the baseline data that was pulled out for Harrogate in February. So it breaks it down on the PCN level. And in terms of the target population, we have about 45 patients that have patients with an ACB score of 6 or more, and then we also have about 122 with an ACB score of 3 or more. So my target population is looking at 122 patients over the next 3 to 6 months. The average ACB score for care homes within Harrogate came up to be 4.4, and that's in comparison to the whole of Harrogate, which is 3.96. So there is that room of improvement, and hopefully by the end of the project, some of that ACB score should come down. Next slide, please. So in terms of project timeline, we're almost at April, so the intervention stage will start happening. We'll get our pharmacists to conduct some of these structured medication reviews and hopefully to evaluate the project sort of summertime. So if I am invited again to present, I can share the results in the autumn. Next slide, please. So just a few things that I wanted to end on with. So just in case you are considering a similar project within your own patch. So first thing is always consider non-pharmacologic intervention. This refers back to Aisha's presentation about looking at alternative to medication. The second part is patient identification. So proactively incorporating calculating anticholinergic burden for our patients as part of medication review, so that you are identifying patients that have a high anticholinergic burden and asking if they are experiencing side effects, so then you can minimise potential harm that may be associated with those medication. The other section that I would also like to mention is raising awareness of anticholinergic burden. If the patient is presenting with some of these side effects, relating it, thinking, is this a side effect of an anticholinergic medication that the patient may be on? And last but not least, reviewing patients, always assessing whether the medication is having any efficacy, the tolerance, particular patients that are having recurrent falls, and it's particularly as well as in patients with dementia, for which Aisha mentioned in her presentation too. So next slide, please. So thank you very much, and if you've got any questions, I'm happy to take them now. Otherwise, please put them in the comments box.
Thank you, Azra. That's brilliant. A whistle-stop tour from both of you. So thank you. I know there's a lot more work that goes involved in these things and what we present. We've probably got about 3 minutes for discussion and questions if anybody's got anything. I know there's a few bits and pieces people have been chatting in the chat, which is great. So lovely, thank you. There's a question here about primary care pharmacists aligning their prescribing and deprescribing with their hospital pharmacists. Do you think that happens? Do you think there's more work to do?
I think one of the feedback that did come from the stakeholder meeting is that we are working in silos within primary care, secondary care. Primary care pharmacists are less well established in comparison to our secondary care counterparts, but there is so much more that we can do to sort of merge relationships, collaborate and seek support, especially if we do have specialists within secondary care, pulling in some of the resources to help support our PCN pharmacists.
Lovely, thank you, Azra. That's great. Has anybody else got anything they'd like to share?
Hi, can I come in on speakers? I can speak.
Yes, of course.
I type. Sorry about that. Thanks for excellent presentations. I think your end point about sharing a forum between the different care homes will be really helpful. It came as a surprise to me when I did visit a residential care home that there were no nurses who were doing the drug rounds. And you know, that would present them with immense challenges when we're using branded and non-branded medication, and medicines management say, you know, take your Parkinson's medicine, Cinemet, and change it to co-caraldopa. It will challenge many GPs and others visiting, or Stanek and Stelivos, because of change in secondary care. But I think the idea of a communal forum, they could put out questions. We do with advice and guidance, you know, within the hour with neurologists or geriatricians, and it's a free resource, and it occurs really within, you know, an hour or two, rather than waiting for weeks for a letter.
Great. Yeah, I think quite a lot of what I'm hearing is about, as you were saying, trying to break down those siloed working between the different bits of the system, which it's not easy to do, but if everyone's got the willing, then they'll find a way. Yes, Aisha.
I just wanted to throw a question out onto the floor and just ask whether, is there anybody here who uses non-pharmacological options in their setting, wherever that may be? Is that happening anywhere that you guys are working or that you know of? It'd be really interesting to hear that. And also if anybody's working on polypharmacy, or if you're interested in working on polypharmacy and trying to reduce that, yeah, it'd be interesting to hear from you all on that as well. Thanks.
Anyone want to come in on that? Maybe if they do, or people think of it, they can pop it in the chat, just because I'm conscious of time. The only thing I was going to ask, we're hoping to share the slides and obviously the recording, but Aisha, those posters and things that you created, are they freely available for everyone? So if there's a home or some pharmacists working with some homes, that they can steal them with pride.
Yeah, absolutely. So on that Health Innovation Network website, they're all on there. You can just print them out and just stick them up. Yeah.
Brilliant. Thank you. Right. Without further ado, then I'm going to move on to Irene, who is going to talk about the amazing work they've been doing in Mid and South Essex, looking at improving dementia care in care homes with a digital element focus, which I'm so excited about this because the cats bring me so much joy. So Irene, over to you.
Hi, thank you for having me. Yes, my name's Irene Lucy. I'm head of transformation, but also the dementia and older adults lead across the MSc. So next slide. So it's really a privilege actually to come here today, talk about all the robotic stuff and the tech stuff. I think the one thing COVID has delivered for us is enabled us to actually deliver some real innovative tech. And I don't want to teach you to suck eggs, because I'm sure a lot of you have actually seen the robotic pets that we've introduced. But right at the beginning of COVID, on the first day actually of lockdown, we had a care home that actually contacted us. They had a number of patients that were walking with a purpose, that they couldn't isolate, and they had COVID. It was going right in the care homes. So we delivered, I'd actually got some robotic pets. We delivered a robotic pet to the care home. The next day, they said they couldn't believe the outcomes for this one gentleman, how he's actually been able to isolate and actually he didn't have to go into hospital. So it actually got a knock-on effect for us. We literally were able to roll it out across the whole MSc. It was over a period of about 6 months to a year. And because we had so many people that it actually benefited, not just in care homes, we did it in people's own homes as well. But care homes, absolutely, we've got thousands out there now. And so we do evaluation on everything we do. we can sustain this. So we're asking, some of the care homes are asking their carers to buy them for their residents. We've also got local authorities, and some of our local authorities have seen the benefits, and it's now part of the care package because we've actually been able to reduce the one-to-one nursing within care homes, and also they've actually seen it's helped on their medication, their agitation, their falls. It's reduced a lot of falls. So next slide, please. So this was just everything we've done within Mid and South Essex. We've had to do evaluations because as a commissioner, I have to prove if I'm spending money, I have to prove why I'm spending and the outcomes from it. So what we did for all our care homes, for all our projects, we've asked them to do, they have to sign up to at least let us know, fill in some templates for us. They're not arduous, but actually gives us feedback, because the feedback I can take back to my finance people and say, you know, this is warranted. And when we speak to our local authority colleagues, we say, you know, we need to work together, and here's the outcomes. So for the care homes, and particularly in some of our bigger care homes, we noticed that the improvement in scores went over a few weeks. So you don't get improvement straight away. You get an initial improvement, but actually it's over a number of weeks. You see a lot more improvement. So on the left-hand side, you can see some of the scores we had, like, you know, within the first 2 weeks, there was a 14% improvement in people. And then by week 4, there was a 35% improvement. So we've got 9 scores that we gave out. And as you can see, some of the other scores, this is fed back from the care home staff themselves. This isn't what we've done. It's the care home staff that fill up complete the spreadsheets and evaluations in. So 59% see an improvement in nighttime distress. So they're less agitated, which means they sleep better. And if they do start to wake up and get distressed, they had the cat and they sit and stroke it, and it literally sends them to sleep. And there was 267% improvement in the quality of life scores, which to me is what it's all about. We did have some improvement in medication. It wasn't a lot. It was only about 2%. So we've got all the backing for this. We can share with you the evaluations we've done and the tools that we've used, but we've got all that. So these were just the highlights I'm trying to share with you today. So it's worth having, worth doing. Next slide, please. And this is just a love feedback. So feedback from staff, from carers is immense. You know, that's what we're doing it for. If we can see some outcomes for patients, and if I'm not sure, I've been on the telly, so I'm just going to tell you, I've been on the telly, so some of you might have seen me. We had some patients that were non-verbal, and when we gave them the robotic cat, they started to talk. It was the first time they started talking in like 18 months of being in the care home. So we've had some really good feedback. And some patients, even though they've got dementia, know they're not real, but actually it actually comforts them. And what we say to the care home staff, you don't usually say, oh, you give somebody a cat and leave them. It's there for a reason. You know, if someone's agitated or is getting up and having lots of falls, maybe they want to sit down and they can stroke a cat. And most of the care homes now, they've all got their individual cats. So people have got their own cats with their own little labels on. So absolutely, yeah, it's amazing. Just a little cat or a dog has made a huge difference to a lot of people. Next slide, please. So we've also introduced at this time, because it was so successful, I was able to get some finances to get some interactive tables. And I'm sure a lot of you have seen the interactive tables that are around at the moment. Again, this is because it happened during COVID, which was great for us, people with isolation. Carers weren't allowed to go into care homes. So people were getting depressed. Even the care home staff, you know, it was relentless for them. They needed something to help support people with dementia in the care homes. So we knew that we needed to do something. So we've actually got a lot of interactive tables, and the outcomes have been great. And I think a lot of it, again, goes back to the feedback and to the evaluations. And some of the products that we've put in place actually got their own evaluation. So it's a lot easier. But again, care homes have to sign up to it. It's not arduous. They have to sign up to say, give us that feedback. It may be weekly feedback. It may be monthly feedback. Or a lot of it, the manufacturers can find the feedback themselves. So they don't have to do anything. They just have to use the materials. So next slide, please. So rainbow tables. Rainbow tables are amazing. They're quite large. We gave them to 40 of our care homes. We've now got another, I think another 30 have gone out to different care homes. My area is quite large. It's like Mid and South Essex, from Southend up to Earlscombe. So it's huge. So a lot of the tables are they're interactive. It's actually helped with agitation. with isolation. The care home staff have said, you know, it's amazing. We'll have learnt things about people that they didn't know before, because it can not just do games and puzzles, but it's actually got films on it. It's also, they utilise it because it's interactive for video calling with families. So during COVID, it was nice for families to do that, you know, rather than be on an iPad. They've got a rather large screen, but also it's actually mobile, so it can actually be taken to someone's room. So if someone's bedbound, they don't have to sit and stare at four walls. They've actually got some interactive things that they can do. Again, the feedback is comes back via the happiness program, so it actually monitors what's going on in the care home. So this is all being monitored. So the feedback that we've got, it actually tells you, you know, this care home, and we know which care homes don't use it because we get told by the provider. And if they don't use it, then I take it away and we put it to another provider because everyone wants one. Obviously, it's improved the well-being. The staff said they've learned so much about the residents because there's a lot of things they didn't know. Because as soon as they started showing a film or different types of music, they've got that interaction. And obviously, it enhanced the video calls with the family. Next slide, please. Magic tables. Now, magic tables are amazing. For those that haven't seen them, they're light. It's 360 light. And you can actually utilise them in people's beds, on the walls, on the table. So you don't have to have loads of space. Unlike the rainbow tables and meters, you don't have to have a lot of space for these. And, you know, again, on the floor, completely interactive. There's so much stuff you can do with these, this table. As I say, it's called a table, but it's actually a projected light. And what we have seen from the feedback, again, the feedback is it comes back from the care homes, but also from the provider. And it actually shows us that actually, you know, 93% they've said it's enhanced the mobility for people. So because there's so many different things, they can do it sitting down, they can do it standing up. Some of the games where they've got to move their feet on the floor. So, and actually it's improved, again, staff engagement. But also, I think one of the things, I don't know if Winnie's on here, some of our LD homes have got them. And you have people that are isolated, they don't talk to people, don't interact. But having a magic table like this, they were able to interact. So as you can see, you know, someone's got a keyboard. There's other people who could play the keyboard at the same time. So it actually helped improved group play. Next slide, please. Again, this was just some feedback from the magic table. So say we can share everything. We've got so much feedback, but it really did enhance, and we've actually got some more now. We've actually now got some more going out across the system because we realised that actually had good, and we've got them in our acute hospitals and our intermediate care facilities as well for those patients that bedbound. This is a new thing we're doing is a light bulb. So I'm not going to teach psychiatrists. We all know that people with dementia, their sight goes, and absolutely what their lighting is more than what we require. Good lighting will stop falls. So we developed a project with some of the care homes and just recently, and we sort of bought some lights, some different colour censored lights, and we trialled it in some of the care homes, and it absolutely has now taken off. So we've now got a catalogue of lighting. We've now got local authorities involved. It's now going into patients' own homes, not just the care homes, and it stopped the sundownings. We've been so. One of the consultants said he was prescribing medication because
they put robotic pets in care homes.
Sorry.
Yeah, no, they have them here.
Just
now.
remind everyone to go on mute, please.
Or whatever. They're about 140 quid to buy off Amazon, and should they've changed like patients.
So the lights, I have to say, the lights from the psychiatrist was prescribing someone with medication because they were hallucinating, seeing spiders, and actually they changed the light bulbs into daylight bulbs. And the person didn't see spiders anymore. And we were trying to say to the homes, it's something really very simple that, you know, people seeing shadows, and so they keep saying they're hallucinating. So absolutely for that care home, then they started to change all the different lights. The lights in the bedroom. So we changed lights in the bedroom so people were able to sleep, and if they woke up, they could see where they were and go to the toilet and go back to bed. So we've now rolled it out across a lot of care homes and across our people in their own home. So really has reduced their a lot of isolation, it's reduced their falls, it's reduced the medication, but also I think the care homes themselves have said how nice it is. Some of them put the daylight bulbs in, but actually they change. So if the light outside changes, it changes the lights in the care home. Lighting is really important. It's one of our newest projects we've got going. And so we're lucky we've got our local authorities on board as well. It's really exciting. And it's, so again, the feedback, this is one thing that the care homes have to sign up to, and they have to give us weekly feedback. We have a spreadsheet, and they have to complete the spreadsheet every week to tell us what's happening to that person. Why did you install, you know, was it installed a light in their bedroom because they were walking the purpose in the night time? Were they not sleeping? And again, one of the care homes said that now they've utilised it, they've changed it into their lounge area. People are not sleeping during the day, they're having a good night's sleep. And because they've been able to change the lights to so it's a little bit dimmer of a night time, people that were going to bed late are now going to bed as soon as they start to change the lights. They're now taking themselves up to bed. So patient outcomes has been great, but also I think for the carers that are looking after these people has to be, you know, something that we need to look at. Next slide, please. I'll be very quick. I'm conscious of time. So just quickly, we've also were able to get some motor view bikes. These are bikes that come with a big interactive telly, so you've got to have room, but also they can start to do exercise with their hands or with their feet, but also at the same time they're looking at a film or looking like somewhere they want to go, whether Paris. So they start interacting with the carer and actually start talking about their experiences. They've been somewhere before. So we've just started this gate, and then we're waiting for the further feedback on them. Next slide, please. I won't talk about reiters. Reiters are like the rainbows, but these are only very smaller. We've got them in our acute hospitals, but also got them in our some of our care homes. So very much like the rainbows, but they're very much smaller. They're very like trolley based, so you can actually really wheel them up into certain beds, mainly for the acutes. So next slide, please. Just some of the other things we did. So we've got empathy dolls, we've got talking albums, which we felt, especially for new patients that were going into care home, it was very important, especially during COVID, to make sure that they've actually got some memories and actually having that talking. And we actually gave them into the acute hospitals. Busy boards have been brilliant, absolutely lap busy boards, absolutely have been amazing in our care homes. That's it, really. But I can share everything we've got when I've got loads of slides and everything. Oh, my catch is about to join me. Sorry.
Thank you, Irene. That's brilliant. A whistle-stop tour to some of the incredible pilots you've been doing with some really incredible outcomes. There's some interest in the chat to see some of the evaluations and the outcomes. So if you're able to share whatever you can share, I think would be of real interest. And Zena's asked, with the light bulb project, are you coupling that with eye tests to make sure?
No, we haven't, Zena.
Well, the reason I ask, Irene, is there's a big research study that was done by the Royal College of Ophthalmologists, who said that even people with quite advanced dementia could still have their eyes tested. They could use parts of it, and they found that a lot of people were wearing out-of-date spectacles, or they'd got cataracts and all those kind of things, which could be improved without having to do the full test. So I wonder if you get even more benefit from the bulbs if people's eyesight was improved as well.
Yeah, I'll take it on, but yeah, because we did this because of sundown, and obviously, and the issues that we had with people trips and falls and things. So, yeah, absolutely, yeah. So Spencer's on here, so Spencer can take that back with me as well.
Is that a robotic cat or a real cat?
Oh, this is my real cat. I'm so sorry. It's my real cat. I can't claim her.
Lovely. I'm really conscious of everybody's time. I just want to say a big thank you to all of our presenters for some really incredible presentations, really interesting, really varied, and covered a lot of topics in a very short space of time. If anybody does have any questions, please either let me know, or we'll be sharing the slides and things as usual after all of this. So please watch this space for the information. Right, I'm just going to do some very quick feedback and then a little bit of information, and then I'll let you all go. So we're going to use, hopefully this works this time, Slido. It didn't work last time. So I will just quickly put the link in the chat as well. But if you go to slido.com and then type in 587323, and I'll just get the link just in case. So you can do it on your phone, you can do it on your desktop. This is where my computer goes really slow. That's one. And by the power of technology. So first of all, we'd just like to know, what word would you use to describe this event? word or words, doesn't matter, it'll come up as a cloud. These are words that make me very happy. Informative, good, multidisciplinary, even better, helpful. Great. I'll let it get to about 20, 25 people and then we'll move on, just because there's quite a lot of people on the call. Lovely. Informative. That's good. Informative, inspiring and enlightening. I think that's what we should name our network newsletter, Sarah. Lovely, thank you. I will keep all this open, so if you want to go back in and do it at a later date, you can do. So the next question, is there anything that we could do better? If Slido doesn't work, I know some people's phones and things like that don't like Slido, so you can just put anything around this in the chat and I'll bring it all together. No, a longer session. Okay, lovely. Short break. Yep, more time for presentations. Okay. We can certainly do longer. More time. Okay, great. Maybe the next one we do, then we'll have it slightly longer with a short break in the middle and give people plenty of time for discussion. More frequent or longer. Lovely. Great. Yes, they are. We kind of rely on you as network attendees to invite those that kind of like, if you see a gap, we want to know, but also forward on any invites or let me know contact details and I can add them to our distribution list so they get an invite. So it's one of those, we don't know what we don't know and we don't know who's not on the list, if that makes sense. Sarah shared we cover a very wide geography, so we do rely on you to let us know who's not there, so please let us know. Lovely. And then my very final question for this, if my mouse will work, is so the next event is going to be in June. We decided the first one of these that they would be quarterly, so the next one will be in June, but we'd like to hear from you what you'd like to be discussed, or if there's any kind of presentations or projects you'd like to share, please, this is your space to do that now. So just let us know if there's anything you want to hear about. Okay, good. It's probably worth saying, so what we'll do with this information is we do have a steering group, and so what I do is I take these to our steering group, or we as the sort of facilitators take this to our steering group and say, this is what people want to hear about. How do we fit that into the next one? This is great, thank you, lots and lots coming up. I'm just conscious of time, so I'll move on. As I said, this will stay open, so feel free to go back in and add any extra information in that you want. So very finally, a big thank you from us for coming. This is the best turnout we've had so far, so I'm very proud, very pleased. This is my little baby, this network. Just to say, we have got, UCLPartners have got some free online quality improvement training that you can go on and sign up to, share them wide, share them proud. They're very easy to follow. There's been a lot of work and there are more coming around other topics. So we used to deliver in face-to-face training, but the pandemic, as with everything, made us think differently. So they're online and free to do. And I will share the link for all of that in the newsletter that follows this. We have set out the next year's dates. Normally they're an hour and a half, but there seems to be a keenness for a longer session next time, so we can do that. But yeah, so they normally run June, September, December, and then March. So save the dates. I forgot to put the years in, but that's 22 to 23. And some of you may have seen in the last quarter, between the network events, we have started doing a network newsletter in between the events. So that's our way of sharing with you our network, or the network updates. Any we'll share the recordings and things like that. Sarah does a nice little intro. And if there's any kind of initiatives or opportunities that you or you know of that are running that you'd like to share in that newsletter, it's not just ours, it's yours. So let us know, we can put that in there, absolutely no problem. And there are our contact details at the bottom. And I think that's it. So thank you very much for coming, everyone. It's lovely to see everyone. We'll be in touch, and please get in touch with us. Thank you.
Yeah.